described in your manual is, it says everything a nephrologist needs to know about bedside diagnosis and urine microscopy. I made it a little bit less onerous for myself and made it very, expectation has been lowered. It's urine microscopy and AKI. So what I'll do is I'll talk about a few patients, very typical presentations of acute kidney injury, and go through basic steps in examining the urine for making a educated guess to what is involved. So very poignant statement from Hutchison, Sir Hutchison, who I read his clinical methods as a medical student, and really lovely, very basic, very detailed book about how to examine a patient. But it is about getting basics right, like Hamish said. It's not clever medicine. Acute kidney injury is a sick patient being examined carefully, and some thought applied to how to manage this patient. So let's start with a typical patient who would present to acute medical units or A&E with acute kidney injury. Young woman, known, recently found to be hypertensive. GP started on ACE inhibitor. A couple of days later felt much more unwell and presented to A&E with edema and acute kidney injury on the blood test. Firstly, urine dipstick. A lot of A&Es have got a protocol that you dipstick urine of every patient who comes into A&E. And when I do my AKI audits, I've done loads of them over the last 3-4 years, I find that it's actually not that poor. Trouble is, nobody's actually looked at it. Nurse did the urine dipstick, documented in the A&E notes, but after that, nobody looked at it. There are some fallacies of urine dipstick. If this patient had protein positive on the urine dipstick and you sent off a urine sample, and it was proteinuric, all well and good. But if this patient had a negative urine sample for proteinuria on the dipstick, and then you sent a sample away and you found a protein, what condition would you be looking for? Myeloma. So there are some proteins which urine dipsticks can't identify, and usually non-albumin proteins like myeloma proteins you have to be careful about. And same goes for blood. Having a positive dipstick for blood just means there is something in the urine which is oxidizing the reagent rather than actually it is blood. So I'm sure people who've introduced the topic of how to identify acute kidney injury have talked a lot about quantity of urine, careful monitoring of the urine flow. But when we look at the quality of urine, the gross examination, you look at the color of urine, there would be comments about the odor. A lot of times we say this patient smells of UTI. Not necessarily true. A lot of times you get urine smell without getting urinary tract infection, and usually reflects how concentrated the urine is and how long-standing obstruction there has been. Obstructed urine tends to get more smelly. So firstly, the color of the urine. Typically the color we worry about is the red color, and it's the most commonly reported color after the muddy urines which we see in the catheters. So the white muddy urine that usually is seen in patients, can be seen in patients with urinary tract infection if it's very pus cell-filled urine, but most of the time it is precipitation of the phosphate crystals, which are white crystals. So that's why the catheter specimens can be very rich in crystals. Very rarely it can be unusual colors, black color, or sometimes urine which becomes black on standing, typical MRCP questions, but very rare. So these things usually indicate some genetic errors of metabolism, or chronosis or alkaptonuria. White urine I talked about, but people who've had propofol can sometimes have altered color of the urine. It can be white or greenish white hue to the urine. And we talked about ethylene glycol poisoning, where you can get a fluorescent looking urine. But mainly we are worried about muddy, brown colored, cola colored urine or red colored urine. So what do you do if you see red colored urine? So you did a dipstick, it was positive for blood. Most important thing is to spin it. So once you spin it, there is a rough guidance on how to do it. If you look at the studies, they typically say 5,000 RPM for 5 minutes or 10 minutes. But that's the rough amount of spinning that's needed to separate out the particulate matter and the freely dissolved matter in the urine. Only thing you have to be careful with it is use a fresh sample. If you think that the urine, you can't analyze it immediately, you have to refrigerate it. Not freeze it, but refrigerate it. But don't delay examination by more than 4 hours. And that is because most of the things you're going to look for, they will either get lysed or dissolved after that period of time. So fresh sample, if you're going to look at a urine bag sample, pick the sample within the catheter rather than the one which has been collected in bag over 24 hours. And midstream sample if possible. A lot of time we assume the urine dipstick was positive, we assume it was a very cleanly collected sample. But if there is any doubt, try and give instruction to the patient, collect a proper sample if you can. Don't suddenly stop this spinning machine because the things will redissolve very quickly. This is a semi-quantitative test, so though you might be able to pick up the cells and the debris we are looking for, but if you are quantifying it as you would be reporting it, then it's better to have a more exact measurement. So in this patient of ours, we spun the sample, and rather than becoming clear like in the bottom tube, it remained red. So what do you want to know? What's the next test? So the red stuff didn't settle down to the bottom, that means it's dissolved. So these are not the cells. So it can be seen in patients with, rifampicin, it's more orangish colored urine. But in this patient had AKI purely, rhabdomyolysis or hemolysis. So patient who's got large hemolysis can present with red-colored urine, which is not inside the cells. So if you did a dipstick, it should still be positive for blood. So we were discussing this. This was a presentation of a patient who came in with hemolytic uremic syndrome. So you had a patient who was hypertensive, swollen up, red-colored urine. Usually you need large amount of blood lysis to get red urine, but less amount of myoglobin, rhabdomyolysis for red-colored urine. That is mainly because hemoglobin is readily mopped up by haptoglobin in circulation. So it doesn't readily filter out, but myoglobin is not and is filtered out, and urine becomes red more easily. So very large amount of cell lysis. So black water fever, malaria, you get red-colored urine because the amount of hemolysis happening is massive hemolysis. So that was the first step of examination, looking at the color, spinning the urine, seeing what the supernatant looks like. Now this is the second patient, 45-year-old woman presenting with non-specific symptoms, facial rash, joint pains, fever, ongoing for a couple of months, symptoms worsening over time, has taken paracetamol, didn't help, went to the GP, was given ibuprofen, and has been taking significant amount of ibuprofen over the last couple of weeks. Creatinine was 95 on presentation, urine dipstick was positive for blood and protein, and that was the initial examination, went through the same process. This time around, the urine didn't look very red. So just to say, it's a semi-quantitative. When we report the urine microscopy, and you've seen results, it would say so many cells per high power field, or per 10 high power field, or per 5 high power field. You can imagine if you start with a sample which is 10 ml and you picked up random numbers, 3 ml of sample to analyze, it'll be diluted variably. So you will not get the same quantification if you didn't stick to a specific concentration. So guidance is you use 10 to 12 ml of urine, spin it, use 1 ml of the residual urine, resuspend it, and then examine, so that when you quantify it, you know what is the significance of the numbers. So this is the pattern you follow. You get a microscope, you take 1 drop of urine from that reconstituted sample, put it on a slide, cover it with a cover slip, follow a pattern so that you are not randomly examining fields, and typically you go from the top right-hand corner down, go back in, and follow a zigzag pattern and come back to the whole of. You should at least examine 10 to 20 fields to be confident about your observation. So first you do a low power magnification, which is 100x, and what you would see would be pretty unclear. You can pick up large things, and when I say large things, squamous epithelial cells are quite large, casts are fairly large in size, but on a simple bright view microscope, the simple light microscopy, it's very difficult to interpret the structures. And There are ways to enhance the quality of your examination. The best thing is to stain, but we are talking about bedside, so it's very unlikely you'll get a stain sample at the bedside. There are some other ways to enhance your visual image, and this is called phase contrast microscopy. Without phase contrast microscopy, unless you're very experienced at looking at urine, it's very difficult to make out these structures. And this is such a big breakthrough in the quality of microscopy that the guy who did it, he got a Nobel Prize for it. So all you're doing is, as the light passes through the cells, it changes its character very slightly. So the phase of the wave of light changes very slightly. And phase contrast microscope can appreciate that change and make it to enhance the visual quality of your image. So you can see the difference. Without enhancement and with enhancement, you can see quite a big detail of the structure. So the first thing is the epithelial cell, which you can appreciate on a low power view. And second thing are the casts. So you can imagine in a lot of patients with AKI, the urine within the tubules is very concentrated. The flow of urine through the tubules is very slow, and usually the pH is quite high. And that's the best environment for the proteins to precipitate. And what happens is, as the proteins precipitate, predominantly the proteins which are already available on the tubular epithelial cells, these are glycoproteins which are available on the surface of tubular epithelial cells. They'll compact into structures which will take the shape of the tubules. It usually happens in distal tubule or in the collecting duct, and these take cylindrical shapes of the cavity of the tubule itself, and that's what the cast is. If the cast is just the protein itself, then it's called hyaline cast. It's like a glass structure, amorphous, nothing embedded in it, and very refractile. And these are present in abundance in normal health, especially in people who are slightly dehydrated after exercise. You will see adequate amount of hyaline cast. But there is a thought that excessive amount of hyaline cast probably indicates chronic kidney disease. But once these casts start embedding the stuff into their structure, that's when they become interesting. So if the tubular cells get shed into the tubules, as it would happen in ATN, there is apoptosis, tubular cells get shed into the lumen, and they get embedded into these casts. They form this granular structure. Is this the marker? Yeah. So these, instead of that clear refractile material, is now full of very poorly defined stuff. These are not integrated cells, but they are just debris from the cells. And these are called granular cast. And I'll come back to it. Recently, there is some importance associated with it. But in most patients, this is what we are interested in, looking at active urinary sediment. We are looking for glomerular injury. And one way to differentiate whether the patient has got a glomerular injury versus non-glomerular AKI is if they are bleeding from the glomeruli into the tubule. So if the red cells come out of your glomerular filtrate and get trapped into these casts, you know that this is coming from glomerulus rather than anywhere below the glomerulus, because they got a chance to get embedded into these casts. You're looking for red cell casts. These are slightly yellow-brown in color, and if you've got a good phase contrast microscope, you can appreciate the cells inside the cast. Rarely, yes please.
In your audit, how many patients were active, so 3+ of blood, 3+ of protein, or significant sediment on a dipstick, when you looked at microscopy and did?
Unfortunately, most of these slides have been chosen from Google rather than my own work.
Oh no, I just mean
yes.
to say, did you compare how many patients went on to have urine microscopy, and more importantly, how many patients went on to have a significant, that blood, 3+ of blood on the dipstick was relevant to red cell cast?
If you exclude the patients with urinary tract infection, you can see blood and protein in patients with UTI. If you exclude those patients who've got documented evidence of urinary tract infection, we only found 5% of the patients of our AKI, and this was just looking at moderate to severe AKI, AKI2 and AKI3. Only 5% of the patients had active urinary sediment.
And of those, how many had?
I
don't know.
No, I don't have my own data of urine microscopy. There is some data from initial studies looking at importance of urine microscopy in diagnosing glomerular disease, and they produced a figure which varied between 50 to 75% of sensitivity of urine microscopy in picking up glomerular disease. But there is some more importance of looking at these casts. I'll come to that in a second. Very rarely there is other stuff embedded in these casts, but apart from white cell casts, which can indicate ascending urinary tract infection, pyelonephritis, it's very doubtful what other things could signify. Fatty casts are seen in patients who got significant nephrotic syndrome. Now we come to a patient with hematuria. So a 52-year-old man came with painless visible hematuria. Urine depth showed blood and protein. There was no significant proteinuria, there was low-grade proteinuria, and creatinine was abnormal. So now we come to the next step of urine microscopy. When we looked at the low-power view of the urine, we could differentiate larger cells like squamous epithelial cells or the casts. But for looking at anything smaller, you need to magnify it further. So now we're looking at red cells, white cells. Red cells about 8 microns in size, white cells about 12 to 15 microns in size. So significantly smaller things. One thing to remember, yeast cells can look pretty much like red cells. They're round, they can be difficult to differentiate. One simple test is if you've got urine, you're not entirely sure, just put some acetic acid in it. The red cells would lyse, but the yeast cell would still remain there. Rarely you can see atypical bacteria and organisms there. Now, you see a lot of red cells in this patient's urine. You want to differentiate between glomerular hematuria versus tubular, urological hematuria. So anything in the urinary tract, bleeding lesion or stones, which could be causing visible hematuria. Only way to differentiate is as the red cells go through the glomerular capillary membrane, they get deformed. So because they have to pass through those very narrow slits, they get deformed. While the red cells which are coming from the urinary tract, without going through that glomerular basement membrane, they maintain their intact structure. When I initially started looking at it, I found it quite difficult to say what bit is deformed. But I found a very useful clue. Crenated red cells. This is a common finding in very sick patients. So people with liver disease get crenated red cells. Even just having renal impairment, it's well known that patients with AKI can get crenated red cells. Very dehydrated patients can get crenated red cells. So these are still cells with a approximately disc-shaped structure, but they've got a sharp protrusions on the side. And that just means that normal biconvex shape of the red cell is maintained by the membrane as well as adequate amount of fluid in it. As the red cell gets dehydrated, it gets a bit crenated. But once the red cell passes through the glomerular basement membrane or through the passages between the basement membrane, this is what the dysmorphic red cell looks like. You need to have an intact round red cell structure, but rounded blobs on the edges of it. At least 2 or 3 of these blobs would say this is a dysmorphic red cell. How many cells need to be dysmorphic before you say this is a glomerular bleeding? And that's if you look at the studies which looked at urinary sediment, which I was talking about, they've reported anything between 15% to 90%. And that's why there is a variability in the sensitivity of this test. But you would want to see significant number of red cells which are deformed before saying this is all glomerular. But this is what a dysmorphic red cell should look like. So that gives you diagnostic information. You've got an idea, patient got active urinary sediment, there are some red cell casts and proteinuria that indicates the glomerular disease. You start looking for causes of glomerular hematuria, glomerulonephritis, ANCA-associated vasculitis, lupus nephritis. If your patient doesn't have those, you're looking at other causes of acute kidney injury which are not glomerular diseases. But can we gain anything more from examining urine than just making basic differential diagnosis of glomerular disease versus non-glomerular disease? And we know that we are trying to do urine urine assays for proteins like NGAL, looking for information whether we can gain more prognostic information from urine examination. And recently there have been 3 published studies looking at urine microscopy and outcome of the patients. So this is one of them. This is what they use as a urine microscopy severity guide. So they look at the renal tubular epithelial cells and the granular casts. If there are no epithelial cells versus 1 to 5 and more than 6 epithelial cells, and same goes for casts, they score it 0, 1, and 2. And the score quantification has been graded. And when you look at these patients, so on the day of diagnosis, these are about 200 patients in this study. On the day of diagnosis of AKI, somebody did a urine microscopy. Actually, 2 people did urine microscopy so that you could say they were reliable between the observers. And looked at outcomes in terms of dialysis or death, or worsening of AKI. Now, some of these people already have got AKI 3. So they wouldn't worsen their AKI stage. But for rest of them, they would have worsening of AKI or dialysis need. And you can see that there is a clear gradation as the urine microscopy score increased, there was worse outcome. And few other studies have, I think this study used a different grading system. These 3 used same grading system. And they've tried to replicate these results. And it seems the last study was done by nephrologists, so all patients who got referred to nephrologists. This study was mainly done in the ICU patients. So some repeat replication of the results of their study. But the last paper which I was talking about, which was done by nephrologists, they also tried to combine some other novel urinary biomarkers to see if we can improve the quality of information you're going to get from the initial urine examination. So what these 4 groups are, there is no normal here. So you looked at NGAL and looked at 4 quartiles of the assay. So the patients who get lowest NGAL, they did better than the patients who had higher NGAL in the urine. And that held true for patients who we looked at the kidney injury molecule 1 or interleukin 8. And same held true for urine microscopy. So sorry, this is group 1 is the lowest quartile for all of these tests. Group 2 is the medium and 1 quartile up, and this is the highest quartile of examination. Most important thing was if you combined urine microscopy to anything, whether it was interleukin 8, NGAL, or kidney injury molecule 1, that improved your predictability. So you could improve your prediction by adding urine microscopy to any of these novel biomarkers. So maybe there is some more information you can gain from urine examination, but the trouble is how easy it is to get the count of tubular epithelial cells or granular casts in a typical patient who presents to AMU or A&E with acute kidney injury. So low tech, but still not easy to achieve. And like Hemi said, a lot of things are getting better. I think examination of urine in AKI is also getting better, but whether we are interpreting it as commonly as we are doing it, that's the main challenge. Questions, please. I don't think I've got anything else.